Hello, this is Dr. Benjamin Fergus with GRIP Approach. GRIP, as you know by now, stands for Global Rehabilitation and Injury Prevention. Global essentially refers to the fact that we look at full body patterns, full body movement patterns, and the full body integration of injury and how to identify where somebody is functioning well or where they're functioning poorly based on looking at the full movement rather than just a little piece of it or a single body system. So in our classes, we get a question quite a bit. When we evaluate the entire body in these big global patterns, how do we apply those methods to a more specific or perhaps an isolated type of injury? It's a great question. And I think, of course, it takes some time to get used to any method, any approach to be able to do that well and reliably. But I'd like to share with you a little bit how we can apply the GRIP approach methods to a more isolated or specific injury. First of all, we have to kind of agree upon the fact that the environment of global movement typically paints a picture or sets the stage for those more specific injuries to occur in. That's key behind the idea and the concept of injury prevention in training, is that we can create an environment where an individual is more durable and we can identify an environment where potential injury may happen. So here's the story. We'll use me for an example and a wrist injury that I've had to recover from over the past year or so. A couple years ago, I got into Thai boxing and a few other forms of martial arts, and I mostly used lower extremity strikes, the knees, the footwork, the kicks, and a lot of defensive moves. And I did that to sort of save my wrists and hands for my work as a chiropractor and manual therapist. And then I got a little interested in the upper body strikes, and I started working into them nice and slow. And my coach ordered me some wraps for the wrist to protect them. And I wrapped up the wrist, threw the gloves on, and I was feeling really good. And over the next few sessions, I started to spar with a little more gas or a little more power each time that I went. And within a few weeks, I started to notice that I was becoming more limited in my wrist for what I had to do at work. I was noticing that in setups for adjustments, HVLA, or by doing manual therapy, or even setting up or demonstrating some exercises, I was having some discomfort over the lateral side of my wrist. I was noticing a little bit of movement limitation, and my grip strength was down. So I took off of upper extremity sparring for a little over a week and noticed no improvement. And I went in for a sort of a precautionary radiograph to make sure I didn't have any major bone injury. And the scaphoid and the trapezium both looked really healthy. My carpals in general looked very healthy. So with a pretty clean radiograph and my own evaluation of the ligaments and the swelling levels on the wrist, I determined it was pretty safe to start a rehab procedure. So I went into the GRIP approach functional range of motion screens to determine what deficits I truly had. Now, our FROM screens essentially look at how well a single segment of the body can move in each plane away from a sense of neutral in 4 key zones. So I was testing my wrist, which we term the carpus area, into the sagittal plane, coronal plane, and transverse plane. And what I found in that screening is that my major limitation was in the coronal plane. I was having some difficulty with radial duction tasks of the wrist. So if you see my wrists here, left wrist feeling pretty good. I had pretty good radial duction. Now you see my elbow moving out here as I go into radial duction. When we perform this test, we want to make sure that the neck, the shoulder complex, and the core are in a very good position. And as we go into radial duction, once we start to see the elbow leave the plane that it starts in, we know that the pure radial duction of the wrist has stopped and we've started to just internally rotate the shoulder in the transverse plane. So I had both wrists screening. My left wrist was doing very well in radial adduction. As I went into my right wrist radial adduction, I felt like I was running into a block right on the side of the wrist. And if I loaded this in quadruped or any other activity, as I demanded more radial adduction of my arm, the more the elbow would turn out, my shoulder would roll forward, and I'd start to lose my nice equal neutral position of the neck. So I was dealing with an FROM deficit of right wrist or carpal radial adduction. So one other key finding in my wrist is that as I was working, I was finding it much easier to use ulnar adduction versus radial adduction movements of the wrist. I could grasp things a little bit easier with the outside of my hand versus using radial grasp. And I certainly was having some difficulty with my pincer grasp. Now we know from looking at early pediatric development, especially with the work of Professor Pavel Kolaj with DNS that integrates a lot of these approaches, that ulnar grasping on the side is developed first, usually around 4 to 4.5 months. Then around 6 months, most babies start to gain control of radial grasping on this side. And all the way down the line at 8 to 9 months, most children start to be able to get their pincer grasp where they can pick something up very specifically. Now when I looked at my wrist, I noticed that I was having a hard time picking things up on the radial side, and where I was very well coordinated with my pincer in ulnar adduction, as I started to move towards radial adduction, I started to lose a little bit of coordination of that pincer grasp. It was harder for me to grab something, my speed of the pincer started to reduce, and so I saw my developmental control of grasp sort of recess towards those earlier stages, which we see in injury all the time. As I lost control of those newer patterns of radial adduction and pincer, my body started to kind of devolve its control into the ulnar grasp, and my shoulder and elbow position followed that. That's really key when we look at an injury or an athlete that's performing to see which level of development they have in their motor control. So, how do we assess that with what we know currently in pain science and in manual care, essentially the manual medicine arts of physical therapy, chiropractic, and athletic training? Well, we can break down our approaches into a few different levels. One, I could build up my sense of safety in my knowledge about my wrist, knowing that the bones were in good shape, the ligaments were good, I was passing orthopedic tests. So essentially I had to kind of convince myself, hey, everything's safe in the wrist, and start to load it progressively again. That would be very much a psychological based approach to recovering that lost range of motion and the discomfort. Or I could look at a mechanical classification of the discomfort, knowing which mechanical movements were limited, and progressively load in a way that reduced that limitation and my response to it. Or I could look at the joints and the tendons and muscles and connective tissue itself as a structural component and say apply some manual release methods, an HVLA adjustment or a slower mobilization of the joint to free up that movement, reduce the pain response, increase blood flow, speed up healing times, etc. I think those are the three main camps of treatment, the way most of us look at it. In grip, we include a lot of those methods into our hierarchical type of classification for treatment. Our first goal is to first see if we can solve this equation with a motor control based exercise. These exercises are termed global reset strategies, or abbreviated GRS, and they essentially are full body movements that either follow the normal path of development or gait and sort of ingrain control of the lost range of motion as you go through the exercise. The target organ for a global reset is certainly the brain. We want to improve motor control, improve that evidence of safety of movement in a fairly automatic or well-coordinated way. But as you do that, you also get mechanical load into the wrist. You get stretch and strength response into some of the muscles and ligaments and tissues. So a global reset is not only a brain-targeted method, but it uses that neurological motor control framework to drive change. After we go through the global reset, if the regaining of the lost or deficient functional range is not adequate, we then go into the second phase, which is looking at the structures themselves. We call these targeted structural interventions. That may include manipulation. It may include some muscle work, but often we're looking at treating key areas in the connective tissue that help to coordinate several vectors of force through muscle and contractile tissues. If we do go the TSI route, we will likely jump back and regroove that gain with the global reset strategy. If these are effective in restoring the full functional range of motion for a week, let's say, we'll jump into a global performance exercise where we add ballistic strength-based load to build up that durability and make the range that was lost stronger and more durable and more adaptable to change than it was prior to the injury. So that's the basic structure of grip. We test to see what plane the range is lost in. Then we use a motor control-driven exercise to try to regain our lost motion. If needed, we'll use a targeted structural intervention, and ideally we wrap up that rehab approach by transitioning to strength, ballistic, load-based training. This is a slide from our manual for our clinical coronal course, looking at the functional range of motion movement evaluation for Latero-Carpus, or radial duction of the wrist in the coronal plane. To set up this test, you'll want to make sure that neutral zone of reference 2, the shoulder girdle, is well positioned and that does not deteriorate during the test. You'll also externally rotate the forearm to make sure that the brachium and antebrachium are in the same line during the test. The movement is pure radial duction in the coronal plane, and we're looking for an achievement of approximately 20 degrees of radial deviation prior to any loss of shoulder girdle stability or cheating of the brachium or antebrachium out of the coronal plane that they begin within. You may also see the fingers or thumbs flex into the sagittal plane as coronal plane movement of the wrist is lost. This was the key deficit that I was demonstrating that we wanted to regain. The global reset strategy for Latero-Carpus is derived from a simple movement in development, which is beginning in sort of a hand and knee plank position and transitioning to a crawling position. Now, this doesn't follow development exactly. There are some deviations that we've used to drive a more specific gain of motor control of that deficit of EFRAM lateral motion of the carpus. So this is how we set up the exercise. I would begin with my right knee and my right hand pressed into the ground with my arm and femur both perpendicular to the ground. I establish good core control in that lateral bridge where my opposite left arm and leg are off the ground. The transition is a slow one from this position into a forward ipsilateral crawl. So as I transition from that tall side bridge forward to begin an ipsilateral crawl, my body weight is shifted both forward and to the outside of my planted support hand. And when we do this, it demands radial duction of the wrist while still maintaining a nice wide spread of the fingers and adequate control of neutral zone of reference to the shoulder girdle. Now, the movement itself does load the lateral list, such as a mechanical loading procedure may do, but a main difference here is that we're using a full body pattern to integrate that movement into the way the entire body moves. You want to make sure that the elbow doesn't deviate out of the movement and that you don't lose the shoulder position while you try to regain that lost functional range of motion. So in my rehab approach, I would go through this exercise about 30 seconds at a time, which is 3 or 4 repetitions, and then immediately retest that lateral motion of the carpus. Often we'd see a very substantial gain, and this exercise would then become a part of my rehab approach at home. I was using this exercise between 6 and 8 times per day between the patients that I was seeing. And I was also using this exercise as a warm-up to my other fitness exercise after work. Within a few days, I had regained the majority of my lost functional range of motion. And if I hadn't, then I would have targeted specifically the vectorial area where the tissues that support lateral motion of the arm intersect and make that part of my treatment approach. To understand where we place our targeted structural interventions, I'd like you to think about contractile tissues such as skeletal muscle that cross single joints of the body and those that cross 2 joints. When we look at the lateral wrist, there's a couple structures that mean a lot to us for lateral motion deficits. The first right here is extensor carpi radialis longus. As I fade others here, you'll see that this crosses the carpus joint down here at the wrist. It crosses the cubitus, which is the elbow, so it's a 2-joint muscle. And the line of pull of this muscle creates a little bit of extension on the radial side of the wrist, as well as a moderate amount of radial duction. Another muscle vector involved in moving the wrist that's a 2-joint muscle is extensor digitorum. This is actually more than 2 joints as it crosses the fingers. As this muscle contracts based on the line of pull, it creates extension in the sagittal plane of the wrist and a mild amount of radial duction. Between these two structures is a smaller muscle that is a single joint contractile tissue, which is extensor carpi radialis brevis. Again, I'll fade others here so you can see a little bit more. This attaches to the lateral elbow and then again attaches into the backside of the hand. And based on its muscle pull, again, this is creating mild extension and moderate radial duction of the wrist when those contractile tissues fire. Let's put all of these back together. The muscle pull that we get is transmitted through connective tissue. And recent studies show that up to 38% of contractile force put on connective tissue is actually dispersed laterally to the line of drive of that skeletal tissue's contraction. And when that happens, that force is actually driving coordination effort between the multiple different contractile lines in the arm. So we would like to see that the connective tissue that takes up this force is capable of extensibility, because the sensory cells within that connective tissue respond primarily to stretch to help to coordinate that muscle firing. So we're going to look at where the vector of contraction of extensor digitorum intersects with the vector of contraction of extensor radialis brevis and extensor radialis longus. And as I'm circling right here, this is a key area in the connective tissue that we want to ensure has normal extensibility for coordination of that lost radial duction. Okay, so now you have the opportunity to look a little bit at the strategy that grip approach applies to a specific injury. We talked about that in quite a bit of detail, but in your clinical practice or your performance practice, you may need to add in some other tools. I think it's really important that you pay attention to the process, that we don't want to overload manual applications of treatment, needles, rolling, whatever it may be, if the issue is primarily a coordination of motor control deficit. So by knowing a detailed approach, which granted it's going to take some time to get that down in your education, if you can really pick up the approach of screening and get specific, you get really quick results. So the learning pathway may take some time, but it makes you a much more efficient practitioner who can solve both complex things and simple things to make more durable patients and more durable athletes. I hope you liked this quick look at a more detailed, specific location of injury and how we approach that in our courses. Now, everything I discussed for the radial motion or coronal plane movement of the wrist is going to be taught to you in our grip Clinical 2 or Grip Clinical Coronal Plane courses. Our next Grip Coronal course is coming up in Chicago real soon, so hop on the website and take a look at that. We have about 10 seats left for that course. Thank you.